Hi, everybody. This is Dr. Bedient, and today we're going to be going through all of the things that happen getting you ready for a transfer process. So the first thing that people ask is, are we going to do a fresh versus a frozen transfer? And almost universally, the answer is going to be a frozen transfer. The reason for that is because we want to separate out everything we're doing to the ovaries with everything we're doing to the uterus, because we want to optimize both of those things. What we have found when we try and cram them together is that we don't get the best out of the ovaries and we don't get the best out of the uterus, and success rates are lower as a result. And so what we do is we separate them out. It used to be that everyone in the free world did fresh embryo transfers because the freezing process wasn't very good and embryos didn't do very well, and we didn't have a good handle on what we needed to look for. And so fresh really was better. However, now with the types of freezing that we use and how this process is monitored, frozen tends to have much better success rates. And so that is why we use that. Okay. So prior to you getting your transfer, most of the time we want to do a uterine evaluation. That includes the saline ultrasound, which is usually what you've done during your diagnostic treatment, as well as a hysteroscopy. A hysteroscopy is taking a camera and putting it inside the uterus to look around. Now, some people are going to have had this already because we will have found a polyp or a fibroid that needs to come out. And so we will have already done it. Some people do these during the diagnostic parts of our evaluation. Most people will have not had one yet. And so we do what is called a hysteroscopy without anesthesia. We give you medication the night before to help open up the cervix. That can cause cramping throughout the course of the night, and that's normal. And then that day, you lay back and put your feet up, and we go in with that little camera and take a look around. That process is usually about 5 minutes or so. It's pretty quick, and it feels like cramping like you would get during a heavy period. The goal is to be in and out as fast as we can go. Okay. And the big things we are looking for are inflammation or endometritis, any types of polyps or scar tissue, or things that are very subtle that don't get picked up on the other types of tests we do. Once we know that that is good, we will then see where you are in your cycle, and we will start you on meds, getting you ready for transfer. There are a couple of different types of protocols that we use for transfer. And so we will talk about which one we are going to use. The majority are going to be estrase cycles. And so sometimes we precede that with Lupron. So you're on the Lupron for a week or two, and then we check your lining and start you off. There will be other people where we just see where you are in your cycle, and when you get your period, we baseline you and start. Okay, so there's some variation there. With the medications, you're going to come in for a baseline ultrasound, and we make sure that your lining is nice and thin and that your hormone levels are appropriately low. If that lining is thick, if those hormone levels are high, we usually don't start, short of us giving you medications that mean that we would know those levels are high. The reason we don't start is because we want a very clean slate when we start giving these medications. So your ultrasound looks good, your labs look good. You are now going to start taking the estrogen. This is mostly done in the form of pills, but oftentimes we will add in patches or vaginal estrogen, depending on what's needed. You will take these medications, and we will see you approximately a week later, sometimes earlier in some patients, and we'll check and see what your lining is with a vaginal ultrasound and what your hormone levels are. Once we see that your lining is nice and thick and your hormone levels are appropriate, we're going to start you on the progesterone. For some people, this is after one ultrasound visit. For others, it will take longer. It really just depends on how your body is responding, because we're going to tailor it to you, not to some preset, oh, it's day 8, therefore we do this next. I want to make sure that you are getting the response we need before we continue. Once we see that your lining is nice and thick and your hormone levels are good, we then start you on the progesterone injections. These are shots in the backside. They're a literal pain in the butt. They're the most obnoxious med that I give, but it's really, really effective at what it does. When you look at the studies that compare injectable progesterone with vaginal and oral progesterone, injectable really pretty much comes out on top. And so that's why we use it, because it is so beautifully effective. Once we start you off on the progesterone, that's when we can set your transfer date down in stone. And so you will come in the day of your transfer, which is usually about 5-6 days later. And then you'll come in for an ultrasound and blood work, one last check to make sure everything is good. Once we know it's good, we're going to thaw your embryo, and we thaw the best one in line. Sometimes if you have said you really want a male or female, If you have done PGT testing and have that information, that will also impact which embryo we thaw. But in general, the embryologists are going to pick the best looking embryo to thaw and transfer first. When they thaw it, we're going to give it several hours to make sure that it has expanded appropriately and that all the machinery in the embryo has kicked up and is starting again. Once we see that's good, we then have you come in for the transfer. Now, sometimes an embryo doesn't survive and we thaw the next one in line. Sometimes it survives, but it's kind of questionable. And we want the embryo to tell us if it's good and worthy of transfer or if it's really not. And so sometimes we will let it go for several more hours or overnight before we decide to make the decision to transfer. What we are looking for in these embryos is, do they have an inner cell mass, which is the group of cells that will become the baby ultimately? And do they have a trophectoderm, which are the cells that are going to become the placenta? We want to make sure that both sets of cells are in place so that we know that we're setting you up for success. If we are missing those sets of cells, then the embryo is more like an empty shell, and it doesn't have the parts in it that we need to go to a viable pregnancy. All right, so you get to transfer. We're going to have you come in about a half an hour before your transfer time. We will have asked you to drink a lot of water. This is because we want your bladder to be full. That helps us to see with the abdominal ultrasound that we do as we are doing the transfer. I want you to have a full bladder. I do not want you to be in pain. And so if you are really doing the I gotta pee dance, you can always let a little bit of it go. But we do need that big full bladder in order to see clearly. When everybody's ready, you'll come into the room, put your legs up, have the speculum go in just like you've done a zillion times before by this point. We're going to clean off the cervix with a little bit of a soft Q-tip and some fluid. And then we're going to pass the guide catheter through. Then we will let the embryologist know that we are set and ready to go, and they will load up the embryo. And it takes a couple minutes of just sitting there twiddling our thumbs while they do that. And then they will bring the embryo in. We will do one last set of name checks. By this point, we will have already done several. And then we'll pass the embryo through and watch it go in by ultrasound. You can't see the embryo itself, but you can see the drop of fluid that it's in. Once we take the catheter out, it goes back to the lab, and they are going to check and make sure that there is no embryo still stuck in the catheter. If it is, we just put it back in. Afterwards, you're going to rest for a short period of time, and then you can get up and go home, go to the bathroom, all of those things. We do tell people for limitations. I don't want you having sex once you start meds through the time that we see a heartbeat. We also want to limit major gym activity, okay? You do not need to be on complete bed rest. That does not help. There have been studies that have looked at that specifically. You are going to keep continuing all of your meds as you have been. We are going to check blood work in 5 days. The important test is in 10, all right? Hopefully it's positive. And at that point, we'll continue another set of labs a few days later, make sure it's still going up the way it should. And then we will start to schedule your ultrasounds. Your first ultrasound is just to make sure there's a sac in the uterus in the right place. And then your second is where we start to see baby and heartbeat, and it gets fun. And then we will do a final one right around the 10-week point before you graduate from us and go to your OBGYN. You will be on your medications through that last ultrasound because we want to make sure that we are giving as much support to the pregnancy as possible. And that progesterone is really vital. Without it, pregnancies do not continue when you're in a frozen embryo transfer setup, okay? Sometimes we will do what's called natural cycles with patients. Now, most of the time, we don't do these for a couple of reasons, but when we do, they're often modified natural cycles. So you get your period, we do the ultrasound, we start you on a medication called letrozole, and then check and see where your lining is developing. Oftentimes, we will also have to give the injectable cetrotide to prevent you from ovulating before we want you to, because timing is very important. We have it down to the hour of where you are and if you're in the implantation window or not. All right. So there are going to be some people where we do natural cycles, but for the most part, we find that we have the best results with the program cycles using the estradiol and the injectable progesterone. Now, a lot of people ask whether or not we do the ERA test, which is the endometrial receptivity assay. There have been several studies done that show that this is not effective. It's an expensive test and it's painful to do. So why would I have you do something painful that's really expensive when it doesn't give us any benefit? There's a lot of chatter about it in the various groups, but when you actually look at the data, It doesn't support doing it, and so we don't do it. Looking at embryo that we're going to choose for transfer. So things that go into that decision, the morphology or appearance of the embryo, and that is what it looked like before it goes in for freezing. Sometimes that's going to change after, and that's normal. Afterwards, we're just making sure that it is survived and it has the appropriate intracellular structures, intra-embryo structures to go the distance. Things like PGT make an impact. So if you have abnormal embryos, we will not transfer those. If you have mosaic embryos, that is a much bigger discussion. Most people don't have those. I have yet to transfer a mosaic embryo. It would require quite a bit of genetic counseling ahead of time because there are definitely quite a few considerations there. So in general, we don't tend to transfer them, but that's something that is going to be a very individual thing, and we would have to look at those embryos. When you're looking at storage, all of our lab work is done by Ovation Fertility. And so they're the ones who are going to manage storage. And your embryos can stay in storage as long as they need to. They're kept in liquid nitrogen. There are people constantly checking on them far more frequently than they need to, given how long liquid nitrogen lasts, just to check and make sure everything is okay. And that is all run by Ovation Fertility. Every so often, we will have to cancel a cycle. So if someone gets sick and they start having fevers, embryos do not like fevers. We're going to cancel and wait until you feel better. We are going to cancel if your lining is too thick to start off with. And then if it doesn't get thick enough, if it doesn't have the correct appearance, because there's a really specific type of pattern that we're looking for at various stages. If your hormone levels rise before we have given them permission to do that, that's really important. And so we want to make sure that that is optimized too. So the ultimate goal is how can we get you a live birth with the highest success rate possible. So if we cancel a cycle, it's because we have seen something that's like, oh, this is not a good idea. We shouldn't do this. Looking at timing, usually we want people to have a little bit of cool off time after their retrieval. So usually it's about 1 full menstrual cycle. Now that oftentimes matches quite well with what their body is doing anyway. Occasionally we'll start earlier, like put you on a birth control pill right after your retrieval and then take you off a couple weeks later and start. But in general, it's you get the retrieval, you have 1 period, you have downtime where you can do whatever you want, have sex, go to the gym, all those things. And then with your next period, we will get started. When we're looking at the actual transfer itself, I do the vast majority of those for my patients. If I happen to not be in the office, then one of my partners will do it. And of course, if an emergency comes up, my partners and I cover for each other all the time. And that's why it's so wonderful to have people that I trust that I work with. I hope this is helpful for you. I hope you have a wonderful rest of your day, and we'll talk to you soon. All right, bye now.